Ici-bas, pour bâtir l'essentiel pour les générations futures et le progrès de l'humanité. L'attachement pour son pays et l'amour qu'il porte pour sa famille l'ont motivé à rentrer au Niger pour être le premier neurochirurgien nigérien entré pour mettre en place et développer une spécialité qui doit permettre de sortir ses compatriotes de la précarité socio-économique. Alors, qui est le professeur Sanusi Samila? He was a medical doctor. He was also a great neurosurgeon. Et ici, vous voyez, malgré tout ce qu'il a mis en place pour la neurochirurgie, il a également tenté de mettre en place la neurochirurgie fonctionnelle. À l'époque, on n'avait pas d'IRM à Niamey. He was a kind teacher. Et là, vous avez la même année, l'année dernière, notre première promotion de neurochirurgiens formés à Niamey. Ils étaient 6, dont 2 filles, ce qui m'amène à être détrônée. Je ne suis plus la seule femme du Niger à être neurochirurgienne depuis 2009. Et là, la même année, il a été honoré en étant nommé comme président du concours d'agrégation du CAMES en neurochirurgie. Et vous avez les 10 candidats reçus au concours derrière lui. Il y a certains qui sont présents dans la salle. Professeur Sanusi was a politician. Il représentait un député à l'Assemblée nationale et était également le président d'un groupe parlementaire. Il était aimé, il était un leader de sa communauté. Ici, à Zender, sa ville natale, où il a organisé un tournoi de football, tournoi Sanusi. Il était également un bon père de famille. Ici, vous le voyez, avec son épouse et ses 2 premiers enfants. Enfin, il était aimable, sociable et avait des amis à travers le monde. Pour ceux qui veulent connaître mieux le professeur Sanusi, je pense que toute la Fédération de neurochirurgie mondiale, à travers le monde, a aidé à écrire quelque chose sur une publication qui vient de sortir dans World Neurosurgery la semaine dernière. Let me summarize. Let us be among those who find their satisfaction in the pleasure of devoting themselves and in the joy of self. C'est-à-dire, soyons de ceux qui trouvent leur satisfaction dans le plaisir de se dévouer et dans la joie de servir. Ainsi, de grâce, permettez-moi de vous dire, pour nous qui restons, je vous en prie, soyons solidaires pour toujours bien apprécier l'importance de l'instant présent. Je nous exhorte donc, vous et moi-même, à marcher la main dans la main pour une brillante réussite de notre mission dans la voie que nous nous sommes tracés. L'initiative de la République démocratique du Congo en est le bel exemple. Rassembler tous les Africains, du Nord, du Sud, de l'Est, de l'Ouest comme du Centre, sur des ressources propres au pays, dans le but de faire avancer le développement de notre cher continent, l'Afrique. Mieux encore, et plus spécifiquement, elle prouve la solidité de la fraternité entre la République démocratique du Congo et la République du Niger par cette marque de sympathie en baptisant la salle dans laquelle nous nous trouvons. Je dis bien, en baptisant la salle qui reçoit cette auguste assemblée, salle Sanusi Sanuya. Tout ceci m'amène à adresser mes sincères et chaleureux mots de remerciement au président de la République démocratique du Congo, son Excellence, Monsieur Félix Antoine Tshisekedi Tshilombo, ainsi qu'à tous les membres de son gouvernement. Monsieur le ministre, vous serez notre intermédiaire auprès de son Excellence, Monsieur le Président de la République, de l'accueil et de l'assistance réservée aux participants de ce congrès véritablement historique. Permettez-moi enfin de faire une annonce pour le congrès prochain à Niamey. We welcome you to Niamey for ANSA Congress in 15 November 2023. Je vous remercie de votre aimable.
Thank you, Professor Kelani. Under the patronage of His Excellency, President of Democratic Republic of Congo, Félix Antoine Tshisekedi Tshilombo, the first neurosurgeon.
Samuel Roger Kamba. Dear colleagues and friends, it gives me a pleasure and honor to welcome you to the WFNS Spine Committee, Pelvic Spine Post Joint with the CANS Young Course, held from 21 to 26 June 2023 in Kinshasa, Republic Democratic of Congo. With the combined effort, will be hosting a selected group of international experts, not only from Africa, but also from all over the world, participate and share the input of this Congress, expertise and technical advance in spine neurosurgery and education. The course aims to further strengthen African neurosurgery and bring us together again to discuss the challenges and progress made in each of our own countries to a rich scientific program. The course of a life surgery will begin at 27 with the Congress team, scheduled showcasing the latest cutting-edge approach to the spine. You are invited to the very special and hot city of Kinshasa, the capital of the Democratic Republic of Congo. The organizing committee is working hard to produce a rich scientific and social program to assure you all a wonderful time here in Kinshasa in this Samuel Sanusi. Welcome again to you in Kinshasa, and thank you for all of you.
Thank you, Congress Chair. Now, we want to hear from the President of Congolese Society of Neurosurgery, Professor Nsambi. À présent, on va suivre le discours du président de la Société congolaise de neurochirurgie, Professeur Nsambi.
Excellence Minister of Public Hygiene and Prevention of DRC, the Scientific Authority of World Federation and CANS, distinguished guests, dear all, it's a great pleasure and honor to receive to many of you in Kinshasa, capital of DRC, a good country in the earth of Africa, but would describe it as the treasure for the development of our beautiful continent. Within this framework, spine course of WFNS is being for the first time in Central Africa with an excellent session dedicated to young practitioners and learners in neurosurgery. Arriving in Kinshasa means also arriving in Brazzaville, the twin town of Kinshasa, because the two towns are particularity to have the same language, the same climate, and the same culture. So, in the beginning of our Neurosurgeon Society, we wanted to bring together neurosurgeons from Republic of Congo and Democratic Republic of Congo. So, in the name of our society members, we wish you a nice stay in Kinshasa and full success. You must be many for our next Congress of Congrès next year in the same site of Fleuve Congo Hotel. This name is particular because, as I say, the Congo is the name of our two countries of Congolese society, and the name of hotel who receive us for this. With meet our president and our government is the effort to support. I wish you all a nice Congress and a nice day in Kinshasa, the earth of Africa. Thank you.
Merci, professeur. On me demande de faire un petit résumé du discours de Dr Talaja et du professeur Sambi en français. Ils sont en train de vous souhaiter le bienvenu à Kinshasa. Donc nous avons une seule société de neurochirurgie parce que ce sont deux pays frères et unis par notre cordon ombilical qui est le fleuve Congo. Et ici, c'est pour la première fois que nous organisons ce cours. Ce cours a été organisé en Afrique centrale pour la première fois ici au Congo et c'était en collaboration avec les jeunes neurochirurgiens africains. Il y a tout un comité des jeunes ici. Donc il y a un jour dédié aux jeunes et puis 2 jours dédiés à ces congrès. Et en dehors de ça, il vous a souhaité de vivre des agréables moments ici à Kinshasa. Pendant cette période, il ne fait ni chaud ni froid, mais c'est un bon climat pour vous permettre de suivre. Nous vous souhaitons un succès et succès à ces congrès. Très merci. Presentement, now we are going to invite the Council President for his speech, Professor Bello Shehu from Nigeria. Maintenant, nous invitons le président de la société de l'Association continentale de neurochirurgie, le professeur Bello Shehu. Il est nigérien. Merci.
Your Excellency and our friend, actually our colleague, is Dr. Samuel Kamba. Samuel Kamba is a pediatrician himself. So we are not only a politician but also a medical doctor. Our distinguished guests from outside Africa, the faculty, members of the faculty, the president of the World Federation Spine Society, and the president of Congress Society of Neurological Science, and the president of this Congress, our own good friend, Jeff Netulani. Thank you very much for an opportunity to say a word in this opening. I think first of all is, and my colleagues, first of all is really through the minister to thank the government of Congo for this gesture. We are sure this is not possible without the government support to host this. And the Congress is very grateful because in here you have more than 25 African countries represented by young neurosurgeons, not really very old, but neurosurgeons who have qualified in the last 10 years. Residents. So we're very grateful for that. And please kindly pass this thanks to the head of state, His Excellency, please, on our behalf. We're sure you will do that. I also like to update you and to assure you, and I think you know, because you are a doctor, that Congo and the rest of Africa in the last 10 years has made significant progress in the development of manpower in neuroscience. It's not enough. Congo used to be 1 in 68 million, one neurosurgeon for the whole country. Today, they have about 18 neurosurgeons, that's one neurosurgeon. It's still not enough because the population is growing. And I can tell you, you are not doing badly. It's similar pictures across Africa because the population is growing, but we are producing neurosurgeons. And I want to assure you that if we continue in this trajectory, we will get to the promised land. I'm sure we will get there. And I want you to let the President know that we are really the current group of leadership in Congo for neurosurgery is trying to make sure that is done. I want to also let the Minister know that we know you will advocate for us at the AU. We need people like you, doctors, in politics, to be in the EU to let them know neurosurgery is capital intensive, it's difficult. The rest of the world look at Africa as a no man's land as far as neurosurgery is concerned, but it's not like that. And what you're doing today is showcasing that countries can do it, but governments must support us. So we are sure this support you are giving the Congolese brothers will continue. We have seen it really improving. We remember from Didier, one neurosurgeon, Didier, we lost Didier, but we've got Jeff and the others now. We are sure you will help us advocate as the EU. And finally, just before I go down, I will let you also know, Africa is also hosting the whole world in Cape Town come this December. Actually, the president of that Congress, Professor Graham Figan, is here. He will stand up just for recognition. Yes, Professor Graham Figan is going to host us. So we are growing there slowly. I give you this detail because I'm so glad that you are a medical doctor, not only a politician, because I'm sure you next year, 2024, you are going to host the whole Continental Association of Medical Science. We are grateful and thank you very much. Good morning.
Thank you, Professor. Now we are inviting the WFNS Fine Committee Chair de la République, il est ministre de la Santé, Hygiène et Prévention. Merci.
Bonjour tout le monde. Je suis toujours un peu intimidé quand je vois autant de cerveaux capables de résoudre des problèmes de cerveau. Je me rappelle quand j'étais jeune étudiant et qu'on parlait du cerveau, c'était la chose qu'on craignait le plus, avec cette caractéristique du cerveau qu'il comprend tout, mais il ne se comprend pas lui-même. Et je suis très fier d'être ici pour représenter le président de la République, chef de l'État, qui a décidé que ces assises se tiennent, que ce congrès se tienne, que cette formation se tienne, et le président du congrès sait de quoi je parle. J'en profite d'abord pour remercier ces grandes personnalités qui sont ou à la tête de la Société africaine de neurochirurgie, ou à la tête de la chirurgie de la colonne, ou à la tête de la Société congolaise de neurochirurgie, mais aussi tous ces professeurs, tous ces étudiants qui sont ici, et chacun à vos titres et valeurs, je ne dis pas le mot qu'on utilise pour les politiciens, mais et valeurs respectives, eh bien, je vous souhaite la bienvenue en RDC pour ceux qui sont venus de l'étranger. La neurochirurgie est un des domaines les plus importants de la médecine, mais moi je considère qu'il n'y a pas de petit domaine en médecine parce que le corps est un, et ce corps qui est un a besoin de tout le monde. Je suis très fier de voir que cette discipline se discute dans mon pays, ce qui veut dire que nous commençons entre Africains, entre les gens du Sud, à nous entraider, ce qui n'était pas toujours habituel. La flèche était toujours tournée vers le nord, mais je pense que les technologies aujourd'hui nous permettent qu'il n'y ait plus du tout de flèche, il y ait juste de la collaboration. Je remercie particulièrement les Congolais qui font l'effort de se mettre à jour parce que notre peuple a des besoins immenses en neurochirurgie. Nous sommes un pays où, au-delà des maladies infectieuses et transmissibles que l'on connaît, les maladies non transmissibles sont de plus en plus importantes. Le taux de mortalité générale lié aux maladies non transmissibles est en train de shifter avec une épidémiologie qui nous pousse à améliorer nos compétences dans ces sciences qui n'étaient pas toujours abordables. Et aujourd'hui, les plateaux techniques sont de plus en plus accessibles et se démocratisent. Et donc on espère que pour notre peuple aussi, pour la RDC, mais comme on a dit pour le Congo-Brazzaville aussi, nous puissions avoir de plus en plus de moyens de sauver nos patients qui sont malades. Kinshasa n'est que la capitale d'un pays qui fait plus de 100 millions d'habitants, et en 2050 on sera plus de 200 millions d'habitants, ce qui montre l'importance de développer des capacités au travers de tout le pays. Et je remercie Dr Jeff Talaja qui fait beaucoup d'efforts pour que d'abord on donne des réponses immédiates à ceux qui souffrent déjà, mais qu'on prépare l'avenir avec nos jeunes étudiants. Une question qui me rend un peu triste, c'est de voir encore des bancs vides dans une salle comme celle-ci. Alors je me dis, si j'étais jeune, je me serais réassis sur ce banc pour apprendre la neurochirurgie, surtout quand on m'en donne l'opportunité comme c'est maintenant. Donc peut-être un plaidoyer pour qu'on trouve un moyen de stimuler de plus en plus nos jeunes en collaboration avec nos universités pour qu'ils ne laissent pas passer des occasions comme celle-ci, qui est une occasion en or. On vous apporte la science à portée de la maison, donc c'est vraiment dommage que certains bancs soient encore vides. Mais bon, ça c'est un travail que nous devrons faire. Alors pour tous ceux qui font les efforts, que ce soit que j'ai entendu pour le congrès qui aura lieu en Afrique du Sud, à Cap Town, que ce soit au niveau international, le gouvernement de la RDC vous encourage à capaciter de plus en plus nos jeunes à répondre de manière de plus en plus globale à nos problèmes et à permettre à ce que les soins lourds de la neurochirurgie soient accessibles au plus grand nombre. Que cela ne dépende pas des capacités financières des uns et des autres, mais que cela dépend de la solidarité mondiale et nationale pour la RDC. Sincèrement, une fois, je me rappelle, très tard la nuit, il était peut-être 1h du matin, on m'appelle pour me dire on a une jeune fille qui avait une trentaine, qui a fait un accident vasculaire cérébral, qui était en train de saigner. J'ai dû appeler Jeff en pleine nuit pour dire qu'est-ce qu'on fait. Et là, on se rend compte des difficultés qui sont derrière, notamment les difficultés en équipement. Et donc, moi, au nom du gouvernement de la République, je vais tout faire pour que vous ayez, pour ceux qui pratiquent ici, les moyens de pratiquer. Et je remercie déjà l'organisation qui a amené un certain nombre d'équipements pour le pays et qui vont rester et qui vont être utilisés ici. Et cela montre encore une fois, au-delà de l'enseignement, la capacité à être pragmatique, à être opérationnel. Et donc, pour cela aussi, je vous remercie. Au nom du président de la République, Félix-Antoine Tshisekedi Tshilombo, chef de l'État, je déclare ouvert ce congrès et tous ces travaux de neurochirurgie. Merci beaucoup.
Merci beaucoup, Excellence.
On veut juste préciser, le 24, l'Excellence sera encore avec nous pour donner des prix. Voilà. On the 24th, the Minister of Health will be again with us to give gift to the awardees and some prizes. Thank you.
Friends, my name is Mirza Voiskic, but you can all call me Mirza because family name is a bit hard to pronounce. I'm actually from Bosnia. I was born and raised in Bosnia-Herzegovina, but 10 years ago I emigrated to Germany, is where I work. And I want to thank my personal behalf and on behalf of our committee for this great course, organization, and invitation, and I'm very happy to be here. So I will have a short talk on the basic anatomy of spine and spinal cord, of the relevant anatomy for neurological surgeons and all other surgeons who like spine. So the objective would be to understand the basic anatomy of the column with regions, numbering, junction areas, spinal ligaments and muscles, to comprehend the specific anatomical details, differences between the vertebral and spinal cord segments, numbering and locations of the existing nerve roots in the different regions of the spine, relations to the body cavities, and basics of anatomy and vasculature. So we will differentiate between spine anatomy and the spinal cord anatomy, and for segments and regions of the spine, very basic things: 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal vertebrae, which all have their specific anatomy, which we do not need to know in every anatomical detail, but there are some surgical things which are very important if you want to perform safe surgery for a patient. Surface landmarks, separate talks. Facet joints of the spine, which are located laterally and connect all of the vertebrae, and the spinal ligaments with a division in intrasegmental and intersegmental, especially important ligamenta flava from C2 to sacrum, which connect laminae, interspinals, and intratransversal ligaments, and anterior and posterior longitudinal ligament. There's also a disease connected to both of these, morbus forestier or OPLL, supraspinal ligaments, and the specific anatomy of the craniocervical junction. Paravertebral muscles, important as well as for the cervical, as well as for the lumbar spine, especially in the cervical spine for the anterior approach, knowledge which is, like I said before, not important to know in every detail and every anatomy of the other vertebrae, because C1 does not have a corpus, it has 2 arches and a latellar mass. Important to know the important distinction and the relationships to the vertebral artery and its the pedicle screws, which in this area, which we do not recommend to perform without some kind of. And it is also something which I hope that we will be able, even if it seems easy, even if it seems like something which is pretty straightforward. You expose the bone and took the lamina out. Even then, if you are not aware of these very specific anatomical considerations, you can produce major complication. And of course, the anatomy of the craniocervical junctions, which will be a part of the separate talk on the stabilization techniques.
Stability, that is the basic requirement for the anatomy, as done by Mirza. The concept of stability is there is many reports in the literature on the number and many number definition of spinal stability, but the consensus is lacking. According to White, clinical stability is the spine abilities under physiologic loads to limit patterns of displacement in order better. Thank you.
So thank you everybody to give me the opportunity to be here and to exchange my experience and my longer fellowship that I spent in Europe, come back to my country. I'm originally from Congo, and I'm very proud to be able to exchange all these basic aspects and concepts of the spine. So my topic will be the spinal instrumentation, and of course, spinal instrumentation is what we use every day, and what we try to include in our current practice. But we start with the past, with the history, and in the spine, 100 years ago, we have no instrumentation at all, and we only use bone graft to obtain the stability described by the professor. We have been waiting not so long time ago in the 1949 to get the first validation to treat the instability problem and scoliotic problem, and we have Harrington that comes with his longer rod with two hooks at the extremity to stabilize the progression of the deformity, a situation that was not solved until this moment outside with the CAT system. So he designed the first long rod system and the stability, but we have a lot of problems with this. We have fracture of the instrumentation, and finally the stabilization was obtained in the long term. So here we have developed a lot of new fixation system, metallic internal fixation device, and the Harrington designed the first screw. Here you see the first design that we refined a few years ago, and it was the first draw of what we use every day today is the pedicle screw. So until this time, not longer ago, we had no screw at all. Other pioneer work also in the development of instrumentation, and in the same topic, the deformity, we had rod, we had bending rod with the specific fixation system, the Congrès system with all those one that were stabilizing with right correct deformity of the patient, but in this case also the stability was not obtained in the long time. So this is the reason why some pioneer work and design of society the new stabilization system that was offer the opportunity to better correct, to better modify the deformity. And why we need this screw? Because it offers a best anchorage and a better biomechanical correction. We are able to apply 3D force and obtain a good stability in the system. So major screws design have particularity. All the screws are not the same. They have thread stitch, inner diameter, heads, that all specificity of all this information that very important to use and to dedicate specifically in the topic that where you want to work. Cannulated screw and the test screw is also some innovation that help us to work in bad bone quality. And as you see here, you have different design of screw, different design of hook that we still use in the system. And you see also one of the first system that we used in which we had through the screw by a fenestrated screw directly inside the vertebral body cement to increase the stabilization of the screw. That was made in 2005, and that was the early time for this type of development. Very easy breakage of the bone graft if you have compression just in between the two different stress and the different modulus, young modulus index between the two surfaces. So very important to see that we can have a lot of different cages, but all these cages have not the same biomechanic, they have not the same bone support, they have not the same stability, and the risk of subsidence increase if you have a very short cage with a very high modulus index. So the other things that in the development, we will see that correction of the angulation is very important to obtain a very balance. And growing, we see that some cases can be adapted with modulated screw and modulated cage with different angulations. If we want to improve the osseointegration, we see also that some cages have designed in 3D to optimize the footprint, but also to optimize the graft surface and also improve the load sharing, avoiding stress shielding. So the axis we see, posterior axis, we have there some benefit for the surgery, but also we have some limitation, cage volume, bone graft volume around in the cage, limited and risk. If we go to the cliff, mainly the same design, but on banana cage, we have benefit in the surgical approach, but we have sometimes to correct the angulation that is very high until 30 degrees. And so we are able also to stabilize directly with using a plate or directly with screw inside. For the lateral approach, you see the cage, the axis, all bone can be reduced, but the cage is very large, offer a very large footprint, and the benefit is that there is some limitation for the surgery and some technical specificity, but you have a very large surface cage with a high volume of graft and also the possibility to make some correction of angulation. But why angulation? We will see that it's very important that the sagittal balance is respected or restored during this procedure. And it will be very important to optimize, and if you see also in the normal situation, in L5S1 or L4S5, the height of the natural angulation is already 50 degrees for L5S1 and the mean. So you have to optimize and place the perfect adapted cage if you want to be able to make the correction of the sagittal balance. Of course, in the cervical instrumentation, we have also a lot of opportunity. We have the anterior cage, the anterior plate that we have to use a different technique. We have different shape, internal stability with plate or with screw inside the cage, and that give us the better stability. But we know also that also in lumbar and in cervical, we can try to maintain the dynamic mobilization using the prosthesis with specific biomechanic capacity, and these are all the instrumentation that are available. In the posterior fixation system, we have the screw for the posterior cervical, but also the plate for the occipital cervical fixation system, and different rods with connecting and with transition shape, because if we want to make a construct from the cervical to the thoracic, the diameter of this rod need to be adapted from the different level. So all the systems are available, plate, rod, hook, and connecting system to optimize the stabilization and to offer you the opportunity to correct how you want to correct. Thank you very much. But the inventor that make the larger amount of cases same stuff, with my experience,
est-ce que pour vous, la greffe postéro-latérale est encore valable par rapport à l'instrumentation actuelle? Est-ce que vous avez rencontré des hyperostoses liées, n'est-ce pas, à cette greffe postéro-latérale et qui créent des radiculalgies parfois insupportables aux malades chez lesquels on a fait une ostéosynthèse rachidienne? La dernière question était, y a-t-il pas souvent assez de risques lorsque l'on fait des cages intersomatiques par rapport aux blessures de l'étui dural et puis avec des fuites de liquide céphalorachidien secondaire? Difficile à gérer. Voilà mes deux questions.
La greffe postérolatérale, c'est la base de la chirurgie rachidienne. Elle optimalise la fusion et la stabilité. Si elle est placée, elle est disponible. Vous la mettez. Optimaliser la fusion, c'est la clé pour la stabilité au long terme. Quand on n'a que ça, on n'utilise que ça, et ça fait son bon travail. De l'expérience, on a vu que ça donnait un certain pourcentage d'excellents résultats et un pourcentage de non-fusion, de pseudarthrose ou de mauvais résultats de long terme. Des hypertrophies osseuses existent et des rétrécissements foraminaux peuvent se développer en conséquence. Donc, nous observons ça. Après, l'expérience a montré que rajouter de la fusion en antérieur optimalise la fusion et diminue les risques postérieurs. Donc c'est un trend qui s'est fait, mais ça ne veut pas dire que le passé est mauvais. Ça veut dire qu'on essaie de l'optimaliser. Les cages sont des supports qui ont été développés. Les premières étaient en PLIF, posterior lumbar interbody fusion, mais elles donnaient les complications que vous avez décrites avec les risques de brèche durale et ainsi de suite. C'est pour ça que le TIDIP de ARMS est apparu, dans lequel finalement on aborde les choses plus externellement et on diminue ce risque. Donc l'évolution des choses, et c'est ce qu'on va voir en neuro, chaque fois une réponse à un problème. Trop d'abord postérieur crée des problèmes musculaires, donc on va travailler les abords antérieurs. Quand on a les abords antérieurs, on a des risques vasculaires, alors on va essayer de faire un abord latéral. Quand on a fait un abord latéral et on a des risques au niveau du plexus, alors on va faire un abord oblique. Et après, vous nous inventerez quelque chose d'autre. Donc je pense que ce sont toutes des étapes. Ça ne veut pas dire que les anciennes sont mauvaises. Ça ne veut pas dire qu'on ne doit pas utiliser ce qu'on a. Si on n'a pas de cage, on met des greffes postérieures. On essaye de faire des corrections, mais corriger sans matériel, c'est difficile. Corriger avec matériel plus greffe, c'est mieux. Corriger avec matériel plus greffe, plus support antérieur, c'est encore mieux. Et hop, ainsi de suite. Il n'y a pas de mauvais. Il y a simplement ce qu'on a et vers où on veut aller.
Merci.
20 to 30 degrees. So long screw that optimizes the stabilization and the rod, in this case for a C1, C2 stabilization technique. Last but not least, the odontoid fracture is the main common fracture that we have seen. We go to the classification.
Program, 3 residents per year, so 21 residents, and we all went to Barry's boot camp, which is like a running and workout class together. And then here's me with my husband. We actually have some animals, including a llama and 2 goats, and not pictured are also 2 pigs, and we have 2 dogs. So we've been talking all about the cervical spine up until now, and I'm going to focus specifically on the subaxial cervical spine. So that means C3 to C7. And we've had some great lectures already going over the atlas and the axis in particular and how you instrument those. And I'm going to focus specifically on the subaxial spine. So C3 to C7, you can see what those vertebral bodies look like here. And really important landmarks that we need to keep in mind, obviously the vertebral artery going through the vertebral foramen, and then also keep in mind that the nerve roots that are coming out here in the cervical spine, each nerve root comes out above the level that it's numbered. So I'm specifically talking about posterior cervical spinal fixation as opposed to the anterior that we just discussed. And so what you really want to keep in mind here is that when you're doing your approach for the posterior cervical spine, there is a lot of musculature back there. So what you're going to do is you're going to find this very nice midline avascular plane. And so you really want to be very careful in that you're not going into the muscle on either side. You find that nice plane that gets you all the way down to the spinous processes. And then you're elevating all of the paraspinal cervical muscles. And unfortunately, that's one of the reasons why this can also be a really painful surgery for our patients, right? And they have a lot of pain after surgery. So once you get down there, I always tell our residents that we really want to have a very, very nice dissection. And so in the subaxial cervical spine, we can place lateral mass screws. And I like for us to get all the way out. Can you see my arrow? Yes, you can. Okay. So I like to really, really nicely expose the entire lateral mass. So what you can see here is, I think of the lateral mass as being like a rectangle. So you want to see the medial aspect of it, the bottom and the top, and you really want to see them as well. And then you want to get out to the lateral aspect of the lateral mass as well, okay? But when you're using your bovie here and you're exposing the bone, you do not want to have your bovie on when you are lateral to that edge of the lateral mass. So in terms of your landmarks for placing your lateral mass screws, you're going to carefully identify the entire rectangle that's all the way around the lateral mass. And then you are going to draw two lines that kind of bisect it and find the exact center of the lateral mass. And so that's the screw entry point that's really at the center of the lateral mass that you've carefully exposed. And it's easiest to place the screw on the opposite side of the spine. So this is different from, kind of every other level in the spine that we instrument, where usually if you're operating with an assistant surgeon on the other side, usually you're placing the screws that are on your side. And the reason for this is because the screw angle for the lateral mass screws is that you're basically angling out and up. So placing your hand against the spinous process, and this is for placing the one on the opposite side of you. So to some extent, these are some of the simplest screws that we place, right? They're angled away from everything that's important: the nerve root, the spinal cord, the vertebral artery. And you can see here an example of an entry point a little bit off from the center of the lateral mass, and then you can see what I'm talking about with your angle that's going to be up and out. So you can read in the books about a few different types of entry points that you can memorize, and you can look at the slight differences between the Roy-Camille technique, for example, versus the Magriel technique. I personally like my lateral mass screws to be angled up more so that they're nice in line with the joints, so looking more like the Magriel technique. And you can see just a few examples from some of my patients. You can see what these lateral mass screws look like when you're looking at them on a lateral x-ray, and also when you're looking at them on an AP x-ray, right? They're angled up, they're nicely aligned with the joints, and they're angled up and out. So this is distinctly in contrast to cervical pedicle screws. So you can see here on the right, we're showing this lateral mass trajectory, and you can see here where the cervical pedicle is, okay? The cervical pedicle is this very narrow corridor along this red dashed line that runs in between the vertebral artery and the spinal cord. And sometimes this can just be a few millimeters. Sorry about that. To be honest, I don't recommend placing cervical pedicle screws without navigation. I always place these with navigation. But the advantages are that you can place.
The patients come with increase in the weakness, and then you have to read those things. And then there can be blood related if the fixation is not proper. I'll show some examples of those. So this was a paper by STF which mentioned all these complications. And the most common complication is dysphagia. Other complications are all actually quite rare, and maybe you may see once or twice in your lifetime. So in vascular
possible complications. You can have injury to internal carotid artery, external carotid artery, or vertebral artery. I've never ever seen this complication. In some patients that have normal anatomy, you can damage them. If the injury of blood, and you will be in a panic to do to think what to do. So simply just press it whichever way you can to stop the pain.
Lagos. It's important to understand the anatomy of the cervical spine. And when the anatomy is well understood, then you will know where to go, where not to go, and especially where you have important structures to avoid. Of course, 7 cervical spine, C1 atlas, C2. I think for most of the posterior spine surgeries, one could do very well with a loop, with a magnifying loop. But CM, except you're very sure, because one common complication could be mixed levels. For posterior approach, it could be as the only approach or in addition to anterior and in neoplastic changes. The main advantage for posterior approach is for multiple levels, and it's also easier than the anterior approach, because in anterior approach you probably need some magnification. You of course need to be more versatile with many important structures and vessels anteriorly. There are less technicalities when you have to go posteriorly. For laminectomy, the indications are the same as mentioned earlier on, but the instrumentation has to be thought about, the type of keratins to use, and of course the drills that makes work a lot easier. Another important consideration is the facets. The complications vis-a-vis kyphosis and neck pain. For cervical myelopathy, and if you have to go posteriorly, it is important to use the cervical keratins with very slim foot plates because of the possibility of actually compressing the structure which you are trying to decompress. So you have to look at the type of keratins that you're using. I guess the one on the left, the one on the right.
Fitting presentations. My question is to all presenters. How often in your practice do you navigate your screws, cervical screws? Thank you.
For almost 5 years, and I pretty much navigate everything at this point. So for navigation systems, we have 2 different platforms. We have the stealth navigation. I don't know if you're familiar with that. So that's a Medtronic-based one. You get an intraoperative O-arm spin, which is a 2D CT scan, and then you're able to navigate every instrument off of that. But it does take time because you have to do the spin. So we also, a couple years ago, got another system which is called 7D, which is machine vision navigation. So that one works off of a preoperative CT scan. And so intraoperatively, you bring the camera over the field, it takes a picture. That's the flash registration, which takes a few seconds, and then it registers it to the preoperative CT scan. So because that is so fast, I have actually just started using it routinely in all of my cases. It's very good in the cervical thoracic spine. And I've found that even though I never had any, complications from misplaced lateral mass screws before, now I can just make sure that they all look perfect. And I can maximize the lengths. I went from pretty much always putting in 12 millimeter all the time to now, based off of what I see on the navigation, I can try to put in 16s, etc., and try to get better purchase. But that is really just because of the opportunity that we have with that 7D system, and that it doesn't take more time. Because otherwise, if it would be an intraoperative CT scan, that takes time, and I wouldn't do that just for the lateral masses. But for cervical pedicle screws, I always navigate them.
From my end, there is no navigation in the country whatsoever. I think the best we have is X-ray or image intensifier. But for navigation, the answer is never. I don't know if there are other places in Africa, maybe, but in my practice, the answer is never.
the CT-based platforms are really expensive, but one of the reasons why some companies are coming out with some of the AR, VR headsets is that they're trying to offer those at a much lower price point. So, instead of needing $500,000 US dollars or $1 million to get a system, these are a few $1,000s. Do you think that something like that would be useful in your country?
I think in the future, yes. The cheaper the equipment, then the more the chances that one will be bought. But I must say that there are many instances that a navigation will make the work easier. Otherwise, we have to learn by freehand, by making sure that we run away from trouble. But of course, when that opportunity comes, we shall gladly take it.
qui n'est pas important finissent par tarir. Mais ce qui est embêtant dans le contexte, c'est la dénutrition qui s'ensuit. Alors, donc, gérer la dénutrition conduit à un retard de cicatrisation de cette fistule-là. Alors, la complication est rare, mais nous, on en a déjà eu une fois. Et ce qu'on a fait comme solution, c'est faire la gastrostomie. Ainsi, on assure l'alimentation et on met complètement l'œsophage en repos, et ça permet d'obtenir une cicatrisation ça vient progressivement, mais pendant ce temps, le malade est alimenté par la sonde nasogastrique. To me, that it's clear that fistule from esophagus is rare complication, but we obtained one case of this situation that we don't use a gastrostomy to assure alimentation of the patient during the rest of esophagus. So it's possible to avoid the nutrition during you put the esophagus in the rest. Okay, Dr. Noor.
Do you take do you explain to the patient to have his consent before to do gastrostomy for him? Because I don't know, in my humble opinion, gastrostomy might be a little bit more invasive than to try to don't feed the patient and to see 48 hours. I don't know if what do you think about that? If you will do that always, or because in my opinion, gastrostomy might be a bit more invasive.
A good surgery. Surgery that can be with local anesthesia is not a good surgery. We have advantage to be general surgeon before to become neurosurgeon. So it's easy for us to do this. Sometimes we can be helped by digestive surgery for this gastrostomy. It's not a difficult surgery, but it's good to assure to avoid the nutrition